we need to also find out what's important to measure at baseline. We measure a lot of stuff, but we don't actually know which is really meaningful with respect to the recovery of the individual. So that part, I think, will have to evolve as well.
Hi, my name is Brody, and I am here to welcome you to the Did You Know podcast. I am a physical therapist at the University of Wisconsin Sports Medicine and Spine Center and a professor at Rocky Mountain University of Health Professions. And I am pleased to welcome you and my sister, my little sister.
The younger sister.
Mm-hmm.
Hi, everybody. My name is Jill Thein-Nissenbaum, and I'm a professor at the University of Wisconsin-Madison, where I teach the orthopedics courses, a sports elective, and I am contracted to the athletic department to provide care for the Badgers. Lori and I have been doing this podcast for APTA Ortho for some time, and we've titled it Did You Know? Because not only you, but we have learned a great deal doing this podcast.
Yeah. And did you know Dr. Chad Cook, our guest today, is a tenured professor at Duke University with an appointment to orthopedics, population health, and the Duke Clinical Research Institute, a multi-award winner in teaching, research, and service, checking all those boxes.
Many hats.
A career that includes greater than 420 publications, 4 textbooks, keynote lectures in 40 countries, and being part of 17 million in external funding. Duke is loving that, aren't
Wow.
they?
Holy smokes.
One of the most productive physical therapist researchers. We're thrilled to have him today. And in his free time, who has free time?
Well, he did say when he offered to do this podcast, he did say, well, I get up at 4 a.m.
He enjoys hiking, mountain biking, and spending time with his wife and his mountain home in Western North Carolina. So welcome to the show, Chad. We're thrilled to have you.
Thank you both. I'm super excited to speak with you. It's going to be fun.
So my first question is, so you got 420 publications.
Right.
Yep. Your top 10.
What are your favorites?
All right. This is your Tonight Show top 10. You don't have to give us 10, but give us a few of your, what really resonates with you.
And what do you feel at that point in time? So it doesn't necessarily have to be a current research paper, but what do you feel in that point in time really changed how physical therapists practice? Were there a few that really stand out?
Wow, I have never been asked that.
Oh,
good. And seriously, and I do podcasts for CMET, and I always ask that question to the researchers because I think it's meaningful.
Yeah,
I think my first major publication where I did a systematic review and I looked at coupling patterns of the lumbar spine, which was based on Fryet's laws, and basically found that there wasn't any validity to it, and which questioned a lot of theories around movement assessment of the back. That one still means a lot to me because it showed me that I could do research up there with the researchers.
Mm-hmm.
And then I've done some big data research, so a lot of those the early works where we've tapped data sets and have looked at the patterns within that. That was very interesting to me because it told me that data can tell a story if you knew how to actually look at the data. How does it influence practice? I hope it has. I think it's incremental. Everybody's publication, I think, adds to the big picture. I don't think I've done anything that's completely, about faced what we've done, but I think I've added or maybe subtracted to some areas, and which is the best we can do with this.
Okay. I like the idea of subtraction. I think what it does is unfortunately for students, it makes it a little bit more gray. So you touched on Fryet's rules, rotation and side bending are opposite in the lumbar spine. And is that a big deal? Who cares? And, that's something that's kind of solid that they learn. And then you come along and say, well, does it really matter? And so I think subtraction is equally as important as addition.
Yeah, absolutely. And interesting, you said that data can tell a story.
Yeah.
That depends. It's like the garbage in, garbage out thing. So what kind of data do we have, and what kind of data do we need to keep moving our profession forward?
Well, I think that the data has evolved, how we've captured it and the quality of it within the last 10 years. I think initially we had a lot of administrative data sets that didn't have pain measures or function or anything that really gave you an estimate of severity of the patient. You had cost data, which was still really valuable. You had um, treatments that you could look at and other factors, length of stay, that sort of thing. It's gotten a lot better. There used to be a lot of missing values. There used to be a lot of things that were skipped so that you couldn't tell that story because there were big gaps in it. The best data set I've ever worked with is actually the military database repository. It is amazing. It is so rich. There's so much there, and it's so clean because they won't let it go to the public without actually going in and cleaning it up. So it's a lot better now. Um, Certainly better than it was 20 years ago when I started with it. And I think you can really see strong studies through data sets now.
How do you think patient-reported outcome measures has influenced those data sets? Because I hear, historically, kind of the data that we were trying to capture was, oh, their range of motion improved. Great. But it wasn't necessarily tied to patient outcomes. So can you talk a little bit about how patient-reported outcomes have influenced data set and research?
Yeah, I mean, our proms that we use really tell us where that patient fits within a severity cycle. And without that, as you said, we can maybe gather some impairments or process related data like length of stay, number of visits, that sort of thing. But it doesn't tell the whole story. And
Mhm.
really being able to look at the proms to some of those other factors like how many visits or what's the trajectory of that person based on their outcomes, telling what happens over time, that sort of thing is meaningful. And they're not perfect. Outcomes measures are not perfect, but they're certainly better than no outcomes measures and really measuring what we have.
So, where are we heading in terms of patient reported outcome measures? I mean, a lot of places use the patient specific functional scale, and they will often measure activity limitations. How long, can you sit? Can you stand? Can you walk? But how do we move that forward to things like role? Are you able to fulfill your role as worker, spouse, parent,
Caregiver.
student, caregiver, whatever it is? So how do we move that along the ICF continuum to role?
Well, I think we have to gather quite a bit of outcomes to be able to do that. You know, because of administrative burden, we typically get a functional
Okay.
scale or we get a pain
Mhm.
scale or something like that, but that doesn't tell the whole story, as you know.
Right.
Also, we've relied pretty heavily on legacy measures like the
Mhm.
oswestry and the NDI, which are somewhat imperfect. They kind of
Right.
lack content validity. So
Right.
you've seen some newer tools come along that allow us to measure sleep and anxiety and depression and function and pain interference and a number of other things all within one scale, like the Promise
Mhm.
29.2. They're not perfect either, but at least they were created with patients and
Right.
clinicians and psychometricians so that you've got something that has more validity than a lot of our old tools. We've gone through cycles, right? Oh, we're
Right.
told, don't muddy up your measure with a number of constructs, and now they're saying, well, actually, we need a number of constructs to really get the full picture. So
Right.
it's been a wild ride, but I
Right.
do like the promise that
Mhm.
we've run into some issues with responsiveness with it. So you don't see massive changes in the promise with your patients in a trial, but at least you can compare it to other promise scores from other studies, and it is has multi constructs, so it gives you a better understanding of what's going on with your patient.
Is it a fidelity issue with promise?
You know what I think it is? I think it's a lot like quality of life. If you've ever used the old SFs,
Oh yeah.
36,
Yes.
12, and 8s, it's hard to change some of those constructs within the promise. It's hard to alter sleep.
Right.
Right.
It's hard to influence anxiety. So a lot of times the measures aren't going to be really profound. And it's also a non-disease specific measure.
Right.
So that always affects
Right.
responsiveness because you're not asking questions specific to what that patient is experiencing.
Right. So it's sort of a generic versus a disease-specific
Right.
outcome tool.
Which is
So-
a disadvantage, but the advantage is then you can
Yeah.
compare across multiple
Right,
things.
right,
So
exactly.
Pick your poison, right? That's the
Right.
problem with
Well,
research.
Yeah, or and if you're not worried about respondent burden, you can do one of each,
Right.
You can do a disease specific and the
Correct.
broader.
Correct.
So you recently did a paper on trajectories. You were part of that group that did that. So can you talk a little bit about that paper and the trajectory and patients who had different trajectories to their outcomes?
Yeah, so that was I think it was Trevor Lenz's R21,
Yep.
NIH R21.
Yep.
And we partnered with ATI. So we had access to just an enormous data set. And it also, because it was an R21, it had funding that was specific to two biostatisticians that were just terrific. And they usually advanced methods to track people out over a 6-month period. And we made some hypotheses that were based on a lot of the shorter term data that we've seen in the past, and it really didn't turn out the way we thought. Um, there was a small percentage of people that worsened. There was a pretty good chunk of people that got better, and then there were people that got better initially and then somewhat plateaued.
Right.
And it was very consistent across whether it was spine, upper extremity, or lower extremity,
Right.
which really surprised us on that. So in the windows within those trajectory lines were actually pretty tight. So it's the first that I've seen like that. I've got to give Trevor and the biostatisticians, the praise on that one. They really did a nice job of having the vision for that paper.
So how does that impact what the PT does on a day-to-day basis, or how they prognosticate with their patients? So
Develop long-term plans of care, frequency of visits.
right, exactly.
Well, the follow-up paper we're working on will actually look at
Stay
baseline
tuned.
There's more
baseline
to come.
characteristics. Yeah, we'll be looking at the characteristics of patients who fall within those categories. So that should be fairly informative. And as you know, when you do studies like that, where you try to sub-classify patients, you need a really large data set
Yes.
to really tease that out. And
Right.
people try to do it on these small RCTs, and it ends up being, not very transferable.
Right.
So I think that part, but the real message to me, because I've never gotten away. I spent 9 years in the clinic before I went into academia. And even when I went to Duke initially, I was more time in the clinic than I was in the classroom. So I still think like a clinician. And what it tells me is that people have different trajectories. And that even if you try your hardest and you give your best care, there are going to still be some people who don't improve. And that's nothing on us.
Right.
It's just the way things are. And having knowledge of that, and I know you two probably are like me in the early days of Con Ed, you were told that if you just do things a certain way, everybody will get
Right.
better.
Right.
And the guru in the front, say, hey, 100% of my patients get better from this.
Yes.
And I used to question myself, like, gosh, well, I'm not just, I'm not finding the same thing.
Right.
And, but it's because it's not true.
Right.
And some people don't improve.
Yeah. Should
Can
we
I go
should we
first?
rock paper scissors?
No, I'm gonna go first because
Alright.
this actually is a story related to you.
All right.
So when I graduated from PT school, I started working here at the UW, and I was about 6 months into my job. And you asked me, I will never forget this. We were out to dinner somewhere, I think, having pizza. What are the surprises that you've experienced as a new clinician? And I had two responses. I said, in all those practicals I did, nobody came in with more than one complaint. And in all my practicals, my patients got better.
Yeah.
No one, I did not experience that
Okay.
patient that didn't get better. And I think that's such a great point because I started questioning my skills. Like,
Yeah.
oh, maybe I'm a new
Yeah.
grad. Maybe I don't know
Yeah.
what I'm doing. And I will never forget you
Yeah.
asking me that question.
That's so funny. We're going to come back to the new grad thing.
Okay, great.
But but sort of tied to that, this is something that I think about all the time. And I had this conversation with our residents recently. And that is, a patient comes in, and there are some patients within the first 10 minutes or so, you have a gut feeling like, I'm going to have trouble getting you better.
Yeah.
And I asked them, what is it that you're keying on? And they couldn't quite grasp where I was going, but I'm going to pull it back to your conversation about contextual factors
Yeah.
and all those extraneous things. And so when we talk about data and we talk about impairments and activity limitations and this and that, if you don't include contextual factors, and I think that's probably what they're seeing but couldn't articulate it. Talk a little more about that.
Yeah. So contextual factors, they're very mysterious, and and
Aren't
everybody
they though?
kind of has a different viewpoint on what they were. And you may know this, but in I think it was 23 or 24, we published a paper. It was an
Yes.
international definition of contextual factors because we were very frustrated with the many definitions, and people were calling essentially everything a contextual
Right,
factor.
right.
Essentially, any interactive component during a patient engagement can be a contextual factor. It can be your front office interaction. It can be the lights. It can be the paint that's selected on the walls. It can be what you say to the patient. It can be how long you make them wait. It can be the billing that occurs afterwards. And any of the experiences that they have around that could potentially influence their overall outcomes. And it's been measured in a number of studies, and people say it's anywhere from 15 to 85% of
Oh,
the
wow.
overall outcome. Yeah,
Wow.
which is ridiculous.
Yeah.
It's probably somewhere between 15 to 30% if you look at the good studies, but it matters, right? It's the therapeutic alliance that you build with the patient. It's all of those factors. So contextual factors have to be a piece of that encounter with your patient if you really want to optimize your overall outcomes. What's interesting is PTs tend to be so good at that when we do measure it, we often get ceiling effects. Like if you look at on our recent trial, which we haven't published yet because we've just gathered the 6-month data, we actually looked at I think it's the Wisconsin Alliance inventory, and it's a ceiling effect. There's like a perfect score throughout, which makes the data essentially meaningless. You
Right.
can't you can't tease it out. But there are others that don't have that same ability to optimize those contextual factors, and then you can really start seeing more of a grid of scores. But I got off track there. I'm sorry, but contextual factors are super interesting.
Yeah. So for that new grad, how do they capitalize on those? What should the new grad do? And I'm going to kind of pull you back to that newly graduated PT. What do you wish you knew?
Yeah. Yeah. So I'll answer the first one. What should a new grad do? Well, hopefully they're trained well in patient-centered care and the key components of that. I know I wasn't when I graduated. It was very
Right.
much we called it the banking method. You're going to get this, and then it will lead to good outcomes. But it was very one way. It was a one-way conversation, and it was, expert based. Now it's very much a co-decision with the
Yeah.
patient and the clinician, but this clinician is still using their skills and their recommendations. That's key.
Mm-hmm.
Um, People often make the mistake of thinking that patient-centered care means that you divorce your authority in that case. That's not the case at all.
Mm-hmm.
You're still an expert. You're still sharing that. You just take the patient's preferences and values into account. So that should be part of the training rituals, I think, in most of our programs. The second piece you mentioned is the Dear Newly
Mm-hmm.
Graduated Therapist
Yeah.
paper.
Yes.
That was Jared's idea, and he's probably so I've been out 35 years. Jared's probably somewhere in the 10 to 15 year
Okay.
range, and I
Okay.
think he's more approachable to to younger
Oh, for sure.
graduates.
Yes. Well, there's research out there that shows that you're most relatable to people about 5 years ahead of you in your career. So
Yeah. Oh, I totally agree with that. They
I
they
agree.
see they see themselves in them, so
Yes.
that's probably why.
Right.
But Jared Powell he reached out to me, reached out to Jeremy Lewis and Karen, and he said, "Would you all be willing to, write this? Each person write 2 sections, and then we'll decide what to keep because it's a viewpoint. It's
Right.
1,500 words,
Hmm.
and it needs to be fast." Um, and we put that paper together. It was so fun to write.
Oh,
It
I bet.
was, yeah,
I
it was
bet.
just
I'd
so
have
cool.
a blast with something
Yes.
like
Yeah.
that.
And it was really good. I think it gives good suggestions.
Yeah.
I think it's amazing. What I really like about the infographic is it's not a straight line.
Yeah.
I think, I'm guessing that was intentional, but I feel so many students, new grads, based on technology, everything happens instantly for them, right?
Yeah.
Like they don't remember going to the library in the Dewey Decimal System and finding the Chad Cook articles in the journal. So everything happens so quickly for them. So I feel in this generation, and I'd love to hear your opinion on it, is they get frustrated easily because this patient should get better instantly. I should have instant access to this. I should be able to graduate and get that high level job. I should graduate and be a Chad Cook tomorrow. And I think sometimes they have that mindset. What are your
Well,
thoughts?
I completely agree. I also think what you said earlier really resonates in that they think, oh, shoot, I just lost my train of thought. Can we pause further?
Sure.
Yeah,
Okay.
absolutely.
I lose my train every day.
Oh, man, this is so
So
relevant. I'm sorry.
yeah,
Oh, no,
it'll
no.
it'll come back. So one of the things that I really like about it is the embrace uncertainty,
Yeah.
because well, I've been a therapist. I'm that person that's 5 years ahead of you. So, and the longer I've been in this position, the more uncertain I am and the more comfortable I am telling my patients,
Right.
I don't really know.
Right.
Yeah.
Here's what I know, and here's what I can tell you, and this is my best advice. So, sometimes I tell my patients, this is what I think, but it's actually BS. That is baseless speculation. Doing my best
That's a good one.
based upon like my, what I know at this point. But telling students they don't have to know it all. And I also worry about that, the three-legged stool of evidence-based practice. They really hit hard on the research and evidence piece. And I understand they don't have the clinical
Correct.
expertise to draw from that leg of the stool very much, but they probably need to engage the patient a little bit more and to understand that treatment effects it's hard to measure, and that one little research paper that showed this. And one of the things I see in their notes is, well, this paper found this, and so this is why I'm doing this. And I'm like, well, that's one paper.
Right.
And, the results of that may not be valid for your patient. So,
Wow, you said a lot of really quality stuff there. And I agree, one paper should not alter the way you practice.
Right.
And it needs to be a combination. It needs to be a stream of findings that really lead to a direction. And we don't know everything, and I'm not sure we ever will. And the other thing is the amount of new information that comes in, because
mhm,
we're basically an empirical science, right? It's going to
Right.
change as new information comes in. We
Correct.
should expect that change. The turnover is going to be pretty significant. Probably every 73 days to 2 years, we're going to double the amount of information that we have. We, we've
yikes.
been we've been doing a lot of mechanisms research and trying to find out what is the reason why people actually change, and what's the ingredients behind that change. And I remember speaking at IFOMP last year in Switzerland, and as I was walking out of the building, a guy walked up to me and he goes, "Hey, I really enjoyed your speech, but I just want to let you know you're never going to figure it out." And and
Nice.
it was interesting. I'm like, wow, and for some reason that struck me really hard.
Yeah.
And so we have written a paper. It's still in process, but we're basically saying studying mechanisms is very difficult, and we're probably never going to figure it out. And it's kind of an ode to that person. I don't know who it was, but they basically, I think, are correct. We're never
Yeah.
going to figure it out.
That's a great story.
Yeah. Well,
Yeah.
I think, change, when you talk about, the stages of change and, going through those models, it all sounds good on paper. But when you're faced with that patient, just like the new
Right.
graduate, there's a lot of complexity there. And I take it back to contextual factors, social determinants of health. How long did it take you to park before, you got in here? And what is your mindset when you come in? What are your expectations of the outcome of your care? So, are you expecting to be handed a home program
Right.
to go home and do it on your living room floor? Or are you expecting that physical therapist to put their hands on you and treat you in the clinic? Huge.
Again, so many quality things there, and patients do expect you to touch them
Yeah.
Yes.
and to connect with the area that's their illness. And this is why I had a problem with the really heavy talk based approach that we went through about 5 years ago. Oh, you don't need to touch your patient, or it's low value care to touch your patient. I completely
Oh,
disagree.
oh
And
yeah.
the research is basically on our side suggesting there's real value in either therapeutic touch, but also in validating what the patient expects.
Right.
And Lori, you mentioned something else that I thought was really interesting. You said that the one leg of the stool has historically been, I think, elevated, where the other two have been discounted. I actually have a slide where I have this big bully holding on a much littler person, and the big bully, there's a tag that says the evidence, basically,
Mm-hmm.
from
Right.
publications. And then the little guy is basically patient values and
Right.
preferences and clinical expertise. I agree.
Yeah.
I think we've discounted those other two areas and have really allowed, it's almost like research bullying.
Right.
And as a researcher, I'm saying that. I really
Right.
don't think that's the role of evidence. And it's been used the wrong way, and it's been used um, and it's targeted a lot of people because of that.
Yeah, I agree.
Yeah. So, one of the issues I think with research is this balance of, internal versus external validity. And one of the questions that you had is our focus on average treatment effects.
Yeah.
So when you try to, again, get the fidelity of, all right, we're really going to narrow the sample here so we can find a change, then you water down your treatment effects and you narrow it to a small subpopulation that is not able to be extrapolated. So how do we talk about average treatment effects and how it impacts how we use our data?
Yeah, so this gets into kind of the assumptions of a randomized controlled trial, and everybody's been told the RCT is it's the highest form of
Right.
design, so we should listen to what these RCTs say, and then sure enough, they're causal, they have real value in our understanding of the comparison of one intervention to another. It will help tease out if we're dealing with snake oil
Right.
or if we're dealing with something therapeutic. The challenge comes when we try to apply those findings to an individual patient.
Right.
Because in RCTs, as you say, they measure average treatment effects. So they look at the average result, and there's
Mm-hmm.
going to be a large group of people that did quite a bit better than average. And
Right.
there's also going to be a large group of people who did worse than average. So there's some people that either were harmed or did worse from that intervention, and there were some that actually really excelled from that. But we're only looking at the average.
Mm-hmm.
And we take that average of one group versus the average of the other group. And if one group beats the other group, then we turn around and say everybody should receive that treatment.
Right.
Right.
But in reality, everybody should not receive that treatment.
Exactly. And usually
And
our sample sizes are not large enough to be able to look at those subgroups there
that's
and
for
be able
certain.
to
So
robust. Yeah.
heterogeneity of treatment effects, or
Right.
subgroup analysis, or moderating analysis, all of
Right.
those things that allow you to look at baseline characteristics that are linked to that particular outcome for that given treatment. That's where the real money is. And that's where we're going to be able to look at individualized treatment effects. And then we can turn around to our patients based on what we found in our examination, theoretically, and say this treatment will likely benefit you more than this one, even though this one did better in average treatment effects.
Right.
Right.
So,
Right.
but we're
Exactly.
not there yet. We're
Yeah.
not there yet at all.
Well, and according to your guy in Switzerland, we may never be there.
That's true. Whoever that person is.
But hopefully we'll get closer.
Yeah.
Closer.
Oh,
So
for sure.
one of the things that I've seen a lot now is the new clinician, or lots of people go to the systematic review. Like I'm not going to bother reading the individual research studies. I'm just going to go to the systematic review and get those results. So, again, I go back to garbage in, garbage out. So, what is it that somebody should look for in a systematic review to know that it is of sufficient quality and the results of that are of sufficient quality to apply?
Wow. So I'm not a fan of systematic reviews, but I understand why
Yeah.
clinicians gravitate to them. I mean,
Right.
there are 40,000 papers on low back pain published every
Right.
year.
Yes.
Right.
Nobody has the time to read that. So I get why they go to a one-stop shop. One of the first things I do to look at the credibility of that review is to look at where it was published.
Yes.
There are so many journals now, and so many low quality journals, so many predatory journals. I mean,
Yes.
borderline predatory journals. I mean, there's so many things. So I look at where it was published. I do look at the author list, because I do think there are authors who ethically just do a better job of assessing it. I look at the conclusions they make based on the data.
Yeah.
And also, we've used the term garbage in, garbage out a lot. I've looked at the papers that were included as well.
Right.
Yeah. Right.
There's two ways to look at heterogeneity of studies. You can look at it with, an I squared, it isn't just designed for that. You can look at it for that, but you can also just do the eye test, right? This study is totally different from this study. They
Right.
should not be combining those
Right.
things. They do that for manual therapy all the time. They throw in all these junk approaches, these weird
Right.
stuff,
Yep.
and then
Right.
they say, well, it's not any good. But that's something to consider too, is what did they actually include? And the last thing, if there are more systematic reviews than there are actual RCTs that have
Right.
studied a given area,
No.
we probably don't need another systematic review.
Correct.
Yeah,
Yeah.
exactly. So can I do a little fun segue? Because you talked about predatory journals, and
Yeah.
I believe you were the primary author on a paper titled Temporal Effect of Repeated Spinal Manipulation on Mortality Ratio. Oh, talk a little bit. That paper had to be a lot of fun to write.
So we wrote that. Okay, so we did a sting. We were getting so many requests from predatory journals.
Yes.
Josh Cleland and I
Yeah.
believe Paul Mitkin is the other author on that one. And
Yeah.
we were getting so sick of it to the point where our filters were not even catching all of them.
Right.
Right.
They would populate our
Yeah.
emails every morning. When you would come in, there'd be 20, 30 requests. So I told Josh, I said, I'm going to write a fictitious paper, and the next request I get, I'm sending it to that journal to see if they publish it. So we wrote about a barista who had been dead 5 years, who we did repeated manipulations and brought him back to life, but it wasn't clinically meaningful. Um, and what people don't know is there are hidden jabs at
Oh, yeah.
so many of our friends in there,
Right.
jabs at the McKinsey folks, jabs at the CPR folks, jabs at the Australians, jabs at everybody. And we just did it for fun, and we submitted it, and then it was published with no changes.
Right.
And
Unbelievable.
Yeah.
yeah,
Yeah.
it was, and it's sad because it's probably, I have over 400 papers. It's probably the paper I'm most known for. And it's a joke paper.
Yeah. Everybody should look that one up.
Exactly.
Yeah.
It's a
Yeah.
great one.
Yeah.
It's
Yeah.
ridiculous. Yeah.
Exactly. So, we talked a little bit about designs, RCT, systematic reviews. What kind of designs do you think allow a better approach to helping understand how to treat the patient in front of us?
Yeah. Well, that's an individual decision. So we need something that theoretically teases out individualized treatment effects. And the only thing to do that, and you had mentioned earlier, is either some sort of subgroup analysis of an RCT,
Yep.
or you can do it in observational data too. You just need to be able to fully separate out the treatments and make sure there's not any interaction or contamination in that observational study. There are a lot of different ways to do that. Some are so statistically complex that I could not even do
Right.
justice to explain it.
Right.
The ones that we would be familiar with would be like heterogeneity of treatment effects, subgroup analysis, that would do it. Moderator designs will do it too. And then probably those two are within reach that we can do. Clinical prediction rules were supposed to be like this, but they're too
Right.
simplistic. You need something that's a little bit more sophisticated. There's a great example of being able to do this in the Restore trial. If you're familiar with that one, that was Mark Hancock was the first author. They looked at they used a moderator analysis to look at who really benefited from that cognitive functional therapy. Is there baseline characteristics that predict a person who's going to really excel from that? And sure enough, there is. The really high disability level people are the ones that did much better with CFT than just regular levels of severity and disability. So that's who should be targeted with that treatment. So that's a great example of something you can take to the clinic, to that person in front of you.
So we have a little bit of examples there, but we still have a really long way to go with that.
Definitely.
And we
A
need
really long way.
huge
Yeah.
data sets to get that
Yeah.
to have robust enough numbers to have those findings. So
Right. Right.
And Jill, if I could add one more thing, we need to also find out what's important to measure at baseline. We
Yeah.
measure a lot of stuff, but we don't actually know which is really meaningful
Correct.
with respect to the recovery of the individual. So that part, I think, will have to evolve as well as we use these designs.
Right. And figuring out which have the most fidelity in terms of being able to track without a respondent burden. So I know I have a son who had hip surgery, and every 6 months
yes.
he gets 5 outcome measures to fill out. Okay, so
Wow.
he's 20
Right.
and he had both hips done, so you can do the math on that. And if he fills them out, he goes through and he does
Check,
click, click, because there's too many things to answer. And I said, how did you do that so fast? He said, none of this matters to me.
Oh, yeah. Yeah.
Yeah, none of these things basically measure what I'm doing. So
That's a big problem. That's a content validity problem with some of the scales that we use. And I experienced it myself. When I had frozen shoulder during COVID, I went in and they gave me a scale to fill out, and it asked me
Can you
if
imagine having Chad Cook as your patient?
Oh, God, I could
Oh,
not.
I was super
I
nice.
would be terrified.
But that one of the scales said that, can I fasten my bra? And I said, well, they either must know something or maybe it's a crummy scale. But it's just sometimes we ask the patients irrelevant questions. And if you think about that, when you scale it up, when you get a number value on that, it makes the number meaningless. And that's another reason why we often see a lot of similar findings across studies.
Right. That was just one of the questions I was going to ask. The way we measure our outcomes, how does it lead to similar results? And as somebody who drives by Epic's campus on the way to work every day, and maybe you can talk to this, the electronic medical record, it's a double-edged sword.
Right.
Like, we can collect a lot of data, but at the same time, as the administration and Epic try to ease the burden on the clinician, more and more of our clinic node is looking the same,
Right.
patient after patient, because we have these drop down
Click,
list clicks trying to make life easier for us. But after a while, the patients pretty much look the same. The
Right.
goals look the same. They have drop down lists for our goals and our outcome measures.
Yeah, it's a paradox. You want it simple enough that it can be applied in a clinic and you get something out of it. The challenge is it's not simple. It's complicated.
Right.
A person's recovery process is very complicated, and often we miss key pieces, or we don't ask those key pieces or collect those that are actually meaningful for that particular patient. So you end up with a very harmonious similarity among patients and the inability to distinguish differences. It's a big problem. It's a problem in big data set research. It's a problem in a lot of the outcomes. It's a problem with the promise that we've seen too, because of its lack of responsiveness. So it's a real issue.
Yeah. So, kind of wrapping things up. You ready to wrap things up?
Yep.
Is there anything we haven't touched on that, like, you want to say your piece, something that is really resonant that we haven't touched on?
This has been fun. I want to say that, but I think the big thing is a lot of kind of the overlying theme is interpretation. I think people misinterpret a lot of the information that's out there. They misinterpret the value of that interaction. They misinterpret how powerful some of the things you can say to the patient are. They make assumptions about what the patient needs without asking the patient. I think those things are all critical takeaways. I think interpretation is probably the best. The ability to interpret data and know how that can actually influence your interaction with the patient is probably one of the most valuable things that we can have. And I see a lot of misinterpretation.
Okay, so you're giving a TED Talk. You've been invited to give a TED Talk. What's your topic going to be?
Well, it's not going to be bringing a barista back to life, although that would be that would be funny.
That would be funny.
I mean, definitely the direction I've gone recently is trying to understand why people get better, and that's the mechanisms piece. I'm not sure we'll ever figure it out, but it's so interesting to look at the different reasons why that. And then the other piece is really around interpretation, and it's like, what do we really understand from this? What does it really tell us? And that part of it, I have seen, and I've tried to incorporate that in some of the talks I've done, and I see a lot of glassy eyes on
Oh
it.
yeah. Yep.
So I think that part is hard to even understand because it's complicated.
Yeah.
I think it's very hard, even
Yeah.
for a seasoned clinician, and then
Yeah.
you add new grad into the mix who
Yeah.
wants that answer immediately. Just cut to the chase.
Yeah.
Tell me what I need to know. It becomes very
Yeah.
difficult.
Yeah. Complicated I think, is the key. And then if you're comfortable with complicated and uncertainty and you lean into the patient, that's your best option.
It is. It's the best anchor.
Yeah.
The patient's your best anchor.
Yeah. So awesome. Well, thank you so much. This has been a lot of fun. We really appreciate your taking the time to meet with us and share this with the Orthopedic Academy
And
I-
nationwide.
and nationwide. Yep.
Yeah. Thank you. And I recommended 4 a.m. You all didn't go for it, but thank you for having me.
Sure. You bet.